So we want to thank you for joining our webinar. It's Collaboration Essential for Addressing Substance Abuse and Promoting Recovery. It's presented by the Great Plains Quality Innovation Network, and we're the Centers for Medicare and Medicaid Services, Quality Innovation Network, Quality Improvement Organization for North Dakota and South Dakota. Many individuals are turning to negative coping methods in an effort to manage mental health issues triggered or aggravated by the ongoing pressures of the pandemic and other issues as well. Collaboration among healthcare and community partners is essential for addressing substance use and promoting recovery. Custer Health and Project Recovery are going to share best practice for expanding access to behavioral health and substance use recovery services using innovative programs and approaches. So I'd like to introduce today's speakers. We have Jennifer Pelster, who was born and raised in North Dakota. She graduated from the University of Mary with her BSN in 2008. She has a background in correctional nursing and has worked in the state penitentiary, the youth correctional center, and the jails. Through these experiences, she developed a passion for HIV, hepatitis C, and STD testing and counseling, and this helped her to recognize the increasing need for a syringe service exchange program. She's been a public health nurse with Custer Health in Mandan since 2013, and she helped get the Good Neighbor Project started in 2018, which is the first syringe exchange program in North Dakota. Dr. Stephen Temain practices modern primary care medicine with an emphasis on cancer and cardiovascular disease prevention, as well as improved human performance, both physical and mental. In addition to modern medicine, Dr. Temain focuses on evidence-based nutrition and lifestyle modifications. He's certified to prescribe Suboxone, the most common drug used in medication-assisted treatment for opioid addiction. Helping patients who struggle with opioid addiction is one of his professional passions. And in his spare time, he enjoys triathlons, marathons, and anything active. We want to thank you both for sharing your expertise and knowledge with us today. Dr. Temain, please begin your presentation.
Thank you very much. You can go ahead and move to the first slide here. I know that if I just pointed out that in Rapid City here we run an evidence-based MAT clinic, a lot of people would know what that means, but I suspect there's a fair number of people that would not know what that means. And so I just wanted to spend a few minutes kind of getting everybody up to speed on the main kind of condition that we're dealing with and some of our innovative approaches. So just briefly, what do we call it when someone has a physical addiction to opioids? It's called opioid use disorder, and it's important to recognize that this is a chronic relapsing disease as opposed to a character deficit. It has very low cure rates, and it's typically something that's managed by a multidisciplinary approach over time. Next slide, please. This is just not to be reviewed significant, but it's just a rough outline of diagnostic criteria. First, it's on a spectrum. The more objects you have, the more severe your opioid use disorder is. Basically, it's sort of the classic cases that struggle with opioid addiction, such as those who have found themselves positive for urine drug screens, multiple pain contracts that have been broken, people that are diverting meds, sort of the normal things you would consider. Next slide, please. And so MAT, which is the clinic and the service that we offer here, and by the way is relatively standard throughout the country, is just a service that provides FDA-approved medications that help with the typical symptoms. Next slide, please. And it's important that when you have a patient who is an opioid use disorder patient, that you recognize that their treatment plan is really based on a spectrum. Of course, it would be someone who has opioid use disorder, such as someone who's a heroin user or someone who abuses prescription narcotics, would eventually be substance-free. In many cases, it just isn't practical. And so our goal is really to move the patient from wherever they are to wherever we can get in a manner that's effective. That works much better than forced tapering or forced protocols, which over numerous studies, over multiple modalities, does fail. So if you go to the next slide, you'll see this kind of what we refer to as harm reduction within their spectrum of substance. Next slide, please. And you can really compare a patient with opioid use disorder to other diseases as well. So, for example, if you had a diabetic that perhaps if you disregard the genetic components, but just considered lifestyle choices, you could have a diabetic who's various degrees of control based on the way they're taking care of themselves. And their medications really are also on a spectrum. Our goal is to get them as limited medications as possible while controlling their disease. And it's the same thing with opioid use disorder. Next slide, please. And so if you compare the two, just any chronic medical condition versus opioid use disorder, this is a very important point. Patients who have opioid use disorder are frequently discriminated against. They're frequently blamed for a relapse. I can assure you that the majority of the patients have very low self-esteem. And a lot of times there's stigma associated with their treatment, which really results in poor access.
So I had to call into my phone.
When you compare that to diabetes, you can see that it's the opposite. You know, any provider can really take care of someone with diabetics. Nobody blames the diabetic for having a bad A1C, and there's certainly no shame. So as a healthcare community, we're really trying to move more towards treat these folks like they have a medical condition, as opposed to treating them as if they have some sort of character deficit. Next slide, please. And so there are several medications that are approved to treat folks that have opioid use disorder. Next slide, please. Most of you will be aware of buprenorphine or Suboxone and methadone. Those are classically the medications that are used to treat opioid use disorder. And this graph is very important because it demonstrates the key characteristic difference. Methadone is very much falling out of favor. Methadone, if you look at this graph, it has a log dose dependency where on the y-axis you have the opioid effect, and on the x-axis you have the dose. In other words, the more methadone you give the patient, the higher the effect. So patients can absolutely get respiratory side effects, including respiratory depression. They can become euphoric, seizure activity. High doses of methadone can be fatal. Buprenorphine, or Suboxone, as commonly known, is a partial opioid agonist, meaning it only turns on to some degree. You can call it 50% for most intensive purposes. It's much safer, and more importantly, the data shows the efficacy for keeping folks from relapsing is equally high on buprenorphine as it is methadone.
Yes.
But it has the added benefit of being much safer, and also the added benefit of being able to be dispensed with higher quantity without the same kind of follow-up because of the dangers of methadone. That's really the only point I'll make about the treatment options that we're doing here in Rapid City. Next slide, please. And then just a tiny bit of physiology, and then we'll get to kind of some of the services we offer. This is a graph that's very important, and I think a lot of people lose sight of this along the way. So what we have here is a graph that demonstrates on the y-axis kind of how you feel if you were to take a narcotic. And then on the x-axis, you have a timeline from initial use to if you've been on it a long time. So if you go to the squiggly white line and you look at it all the way to the left, say that's a normal person, and you take a narcotic for the first time, say you have a dental procedure or a surgery or something of that nature, there's a pretty good chance you'll get a little bit euphoric off of it. You probably won't even appreciate what euphoria is, but you'll feel a little different. And if you do that over a period of time, you'll continue to get that euphoric and normal gyration. But at some point along the way, you develop a dependency, and that's when we start thinking you have opioid use disorder. And you can see that crossover. There's a dot in the middle of the graphic that shows chronic use, intolerance, and physical dependence. And when a patient arrives at that point, they're no longer getting euphoric off the same dose. They're actually bouncing between withdrawal symptoms and normal. And this is where most patients find themselves. That's why if you're prescribing narcotics for somebody, they frequently will require a higher dose because they're finding themselves in withdrawal typically. If you go to the next slide, it'll demonstrate what happens when you give them a long-acting agonist. You can see that it holds steady and it keeps them in a normal state, which they don't have withdrawal, they don't have euphoria, and that's really where you want a patient who has opioid disorder. They're not prone to relapse nearly as much, and they have a much more a life that is much more balanced in terms of dealing with their physical issues. Next slide, please. And then just briefly, these are the major organizations that report on various aspects of medication-assisted treatment. They all have support for it for opioid use disorder as the primary source. Next slide, please. So now, kind of solving the problem, and I'll just take a few minutes here. How do we solve this problem as a community? You know, we have a lot of patients that are addicted to opioids. We solve it as a community. How do we solve it as a state? You know, federally, the country, and really, you can kind of categorize it in three, you know, major buckets. Prevention is critical. You have to have education so that people really understand what they're dealing with. They understand the problem. You have to have a lot of different treatment options because there's a lot of different ways that people respond to things. Medication-assisted treatment is one of them, but not the only way. Multiple modalities are definitely necessary. Project Recovery in Rapid City has focused on MAT because there was a dearth of it here, and that was where we felt we could contribute. Counseling and mental health, very important. The philosophies behind harm reduction, I think, are quite clear that you get a better outcome. Peer support is something that's underutilized and very important. And then, of course, enforcement is critical because you need that to maintain the rest of the infrastructure. Next slide, please. So the challenge is, I don't know how many prescribers are on the line or how many providers there are or administrators in healthcare, but there's a lot of challenges with providing MAT. They can all be overcome, but it does require careful deliberation, a lot of education, make sure it's been done properly, both legally and effectively. And so there's a thing called an X waiver, managing that. Each provider who has a DEA has to get an X waiver, and then they have to monitor the number of patients that they have. That is best done through a team approach where those things are logged by someone who is very diligent and up to date. It requires quite intense tracking, which is really a major reason why people shy away from it. But if you're in practice and you want to do this, don't let that scare you. It just requires a few Excel sheets and a little bit of patience, and it can be done. Next slide, please. So, again, the best MAT concepts that we have tried to employ and that I would certainly recommend to anyone who's interested in that, it has to be evidence-based. SAMHSA, Substance Abuse Mental Health Association, they publish treatment improvement protocols, and that's kind of the Bible. That is the highest evidence base for medication-assisted treatment, and those are called TIPS, treatment improvement protocols, TIPS. They're available online through SAMHSA's website, and that is the blueprint upon which best practices should be based. It's really important that we are systems-based. Any MAT clinic really needs to be plugged into the criminal justice system, the healthcare systems, the ambulatory counseling and mental health services. And then ancillary services are very important. As a primary care provider, we screen the general population for hepatitis C all the time. Every baby boomer gets screened, at least once. And I never find it. I'm a full-time primary care doctor, and virtually I never find it on the general population. But when you screen for it among those who use IV drug use, you find it all the time. Project Recovery, I stopped keeping track after we cured 50 patients of it over a very short time span. And that makes a huge difference downstream because not only does it save those people potentially a lot of very serious medical complications, it also saves the system millions of dollars in expense and numerous other benefits. Next slide, please. I'm almost done. But a couple other things. Telemedicine, which I think will be brought up later. There have been changes in this, and we've certainly learned a lot about how it works. A lot of it is anecdotal. A lot of it's been trial and error. There's not a lot of great studies demonstrating efficacy of telemedicine, but that's something that I do believe is in the works. COVID has changed things quite a bit in terms of making sure we have safe environments. And then, partnerships and providing MAT services to groups that don't really have the ability to do it or practically do it. For example, there are some relatively very large health organizations that were not able to realistically put together an MAT clinic because of various reasons. Through the telehealth and partnering with them, we're able to step in, provide an MAT service that's of the highest quality, and they're able to do the ancillary work such as the scheduling and the urine drug screens, labs, and some of the educational pieces. So I'm happy to talk more about this. I suspect this will be an emphasis later. But there have been a number of telemedicine law changes in regards to MAT, which I'm happy to touch base on. Next slide, please. And then, of course, we make access a key feature, because if you have any barriers to access, you cost the patient's mortality benefit. That's been clearly demonstrated. The number one way to reduce mortality for patients who are addicted to opioids is to have clean access to treatment, meaning easy access, reduce barriers. And so if you go to our website, you're able to click a button, find an appointment, click it, and you're in. Or if you just walk in, we will make time for you. We do not turn patients away. Next slide. I don't want to I got one more minute here. Project Recovery thankfully had a ton of local support as well as state support. By communicating with the various government and local entities, we were really able to capitalize on a lot of teamwork, and that would be something that I think is really necessary. You can't really go it alone with this. You definitely need quite a bit of support. Next slide. And just to give you a sense of our scope, these are kind of our numbers. These are all provider visits based on the years, and so there's a huge need for this. Like I said, in 2018, there was really none of it being done, and we have grown to where we are now with a lot of help and support from other entities. And challenges along the way were many. Thankfully, we've put together a pretty good team, and we're always happy to provide technical assistance to any groups that are trying to put together an MAT program of their own. This is one of our charter missions, is to provide services to anyone who's trying to help access MAT. Next slide. We feel like we made a difference. This is a CDC graphic which demonstrates the percent change in drug overdose death by year and state. We don't take credit for the fact that South Dakota did amazing the time we were ramping up, but we are proud to have been a part of the work that we feel had a contributing effect. And so we get a lot of anecdotal praise from patients, very grateful people. But it's nice to see the statistics where it appears that our work, at least in conjunction with many other people's work, likely had a positive effect. And I believe that's left. And that's it for me.
Okay, thank you. I just want to take a minute to remind everybody to please mute your telephone. We are having to use a telephone line for today's presentation instead of our normal computer audio. So if you just want to double check right now, make sure your phone is muted to eliminate any of that background noise that we might have. And then just as a reminder, yes, Carrie?
Oh, I was going to say I can try to mute all lines and then have Jennifer press *6 and see if that works, if you want me to try that.
Okay. So, Carrie, go ahead and mute all the lines, and then Jennifer, did you hear you'll need to hit *6 on your phone so that we can hear you?
Okay. I haven't done this in a while, so let's hope it works. Hold on. at work. Can you still hear me? Okay, Stacey, you might have to press *6 to unmute yourself. I cannot. Can you hear me? Okay, give me a second. I'll have to figure out. I apologize.
Sorry, that was me. I hit.
Oh, okay, good. I was like, I thought.
My fault.
Okay.
No, that's on me. Sorry about that. So, Jennifer, can we do a test for you? Make sure we can hear you.
Yep. Can you hear me?
Perfectly.
Yes. Okay.
Perfect.
Wonderful. So, I pulled your slides up.
Okay. Perfect. All right. So my name is Jennifer Pelster. I am a nurse at Custer Health. We are a public health unit that serves 5 counties in south central North Dakota. I do have a background in correctional nursing, which included the state penitentiary and multiple county jails across the state. And through this practice, I've realized that there is a huge unmet need for addiction, especially amongst those who use injection drug use. Next slide. So through some research with my current employer with public health, that is one of our goals, is to meet those that have the unmet needs that kind of fall through the cracks in our healthcare system. So what a syringe exchange is, in a nutshell, it's a service that provides linkage to substance abuse treatment disorders, access to disposal of supplies, and also providing clean, sterile injection supplies and equipment, access to vaccinations, and testing and linkage to care and treatment of infectious diseases. Next slide. Some of the benefits of a syringe exchange for the community is it provides access to safe disposal of needles. This also goes into effect or play when you're talking about law enforcement. If they pull someone over and they confiscate paraphernalia, they can dispose of it at our office. We also have a kiosk which provides access to community members who may be diabetic or on immunologic injectable medications. It also reduces the needle stick injuries in the community because there is a safe place to dispose of those syringes. It reduces overdose deaths by providing naloxone education and naloxone kits to not only our participants but anyone in the community. People who inject drugs are 5 times more likely to enter a treatment program and become sustainable in a recovery program. And it also reduces the new cases of HIV and viral hepatitis infections by decreasing the usage of sharing needles and other equipment. Next slide. North Dakota's legislation passed laws in 2017 that allowed for legal syringe exchange programs in North Dakota. So pretty much what it summed up to be in 2017 was that syringe service programs can legally collect injectable equipment without the risk of possession of paraphernalia. So that just means that employees of a syringe exchange cannot be charged with paraphernalia. And then in 2019, it further went on to add that state and federal funds cannot be used to purchase equipment, the needles, syringes, tourniquets, anything used for injecting. And we can only use the state and federal funds for development, implementation, and evaluation of syringe exchange. We also have to be approved by the Department of Health. Next slide. So what exactly is the Good Neighbor Project and what do we do? Next slide. The Good Neighbor Project technically is a syringe exchange program, but we like to call ourselves more of a harm reduction program just because we do encompass so many elements. When a participant comes in, we go over our program's expectations and responsibilities that are approved by our Department of Health. Testing is required, a minimum of once a year, but every 6 months depending on risk assessment for HIV and hepatitis C. Each visit, we provide a client assessment just to get more information to find out what education, what referrals the client might need, any harm reduction that they might need. We do evaluate their immunization status every 6 months, and we provide vaccines free of charge for hepatitis A, hepatitis B, tetanus, and also COVID and influenza. We assess their needs for further referrals and needs in the community. We provide education and Naloxone training. Next slide. Like I previously stated, HIV and hepatitis C testing is required upon enrollment and every year thereafter, more frequently if needed based on their risk assessment. We also offer gonorrhea, chlamydia, and syphilis testing as well. This too is based on client harm reduction risk assessments, and also if they encounter any situation where they may have been exposed. Next slide. Every visit we go through a client assessment that just gets their general demographics, where they're living, if they feel safe where they're staying, how much they're using, what they're using, if they've had any overdose or witnessed an overdose since their last visit, any needs for education and referrals. This can include just general health things, diabetes, heart disease, high blood pressure. We do a lot of referrals for infections, abscesses related to missed injections. We also check their immunization status. This is all documented on a flow sheet so that way each one of our nurses has easy access to this information. Next slide. These two are just some of the examples that we use. The left one is our flow sheet that's on the front of their chart, just so we have their information, kind of a snapshot of their immunization status, their hepatitis C and HIV status. The one on the right is more the detailed encounter that we go through at each visit. It talks about how they're using, how often they're using, what they're using, and then that overdose, as well as if they've reused or shared any injection drug supplies. Next slide. This is a picture of some of our harm reduction supplies that we provide. We provide injection materials ranging from sterile waters, cookers, cotton filters, alcohol pads to clean the injection site, hand sanitizer, along with antibiotic ointments and Band-Aids, tourniquets, and syringes. All participants also get a biohazard container that they must return to us with their used supplies in it. We also provide condoms, safe sex kits, dental dams, lube, anything for potential harm reduction with any sexual activity. We do have clients who perform what we call survival sex. It's where they will provide sexual favors for a place to live, diapers for their children, food, clothing, anything like that. And then we also provide naloxone kits. Next slide. Here again, the immunizations we provide free of charge for our participants are hepatitis A, hepatitis B, tetanus, diphtheria, and pertussis, or Tdap, influenza, and currently we've added COVID-19 as well. Next slide. Each visit, we assess the clients for their needs for community services. These can range from substance abuse treatment, healthcare services, further testing and treatment for HIV, hepatitis C, and other STDs, social services, employment, housing, food, clothing, and tobacco cessation. We also partner with Face It Together. It is a state program where there are peer coaches who are available to our participants at any time of the exchange visit. Currently, we have two amazing staff, Gina and Teresa. What we've found out through surveys of our participants is that they actually prefer to meet with a Face It Together peer coach. Some of the feedback that we've gotten from these evals and surveys is that they have a better connection with these staff members just based on the fact that these staff are actually former injection drug users themselves. So they do know firsthand some of the struggles and stigma that these clients do deal with. Next slide. Some of our main education points are obviously HIV, AIDS, the hepatitis C, STDs. We do a lot of education on harm reduction, which can include safer injection sites, safer injection practices, making sure that our meth users are staying well hydrated, and then other things too, such as the diabetes, heart disease, high blood pressure, those types of things. Next slide. Our naloxone training, we get an overdose history, if they themselves have ever had an overdose, how many times they've overdosed, what they've overdosed on. We go through the signs and symptoms of an overdose. We do have a training video that we have them watch. It is a short 3-minute video that we have created ourselves at the direction of our medical director. They observe us drawing up the injectable naloxone, and then they have to return the demonstration. Next slide. We use what we call a 1-for-1 plus transaction model, which pretty much means that the participant just needs to return used or dirty supplies to continue to get clean supplies. Our medical director, because of limited funding, we have a 20 syringe per week limit. We would like to increase that. But during COVID, we have changed our practices a little bit. Clients used to be able to come once a week with the 20 syringes per week, but we have changed that to every other week with a maximum of 40 syringes, This will help decrease the staff's potential exposure as well as the client's potential exposure to COVID as well. Next slide. This is just a picture of the kiosk that we have behind our building that is available to anyone in the public for disposal. We do have some veterinarians that utilize this, law enforcement, long-term care facilities who don't have contracts for sharps disposal for their diabetics. And as you can see in the bottom right-hand corner, we do ask anyone who utilizes this kiosk to have their sharps in a hard plastic container with a sealed lid. That way we are not potentially exposing ourselves to dirty sharps. Next slide. Currently, since January of 2018, we have 316 enrolled participants. We've given out just a little over 38,000 syringes, and we have had about 77% of those returned. We have collected about 450 pounds of sharps waste in our kiosk in the last 2 years. 54% of our participants are hepatitis C positive. We do refer them for hepatitis C treatment. A lot of our local providers do require them to be clean and sober with proof of negative drug tests for a year before they will start treatment for hepatitis C. But some of our successes is that we have seen a decrease in injection drug use and the amount of supplies that people are sharing. Since the inception of our program, we've given out 1,400 doses of naloxone with 321 reported saves. Next slide. And here's just some more statistics. In North Dakota, our number one drug use that we have reported is meth, along with marijuana. We do provide a lot of referrals for healthcare and substance treatment, as you can see, and about 70 participants are currently homeless. We have seen this number increase since COVID, just with the mental health and the instability that our clients do see. Next slide. Oh, can we go back one?
Did I miss one? Okay.
Yep.
There we go. Sorry about that.
No, that's okay. Our Good Neighbor Project has 2 locations. We have one in Mandan, North Dakota, which is open Tuesdays and Thursdays from 1 to 4 p.m. And we recently just started our second location in Beulah at the Coal Country Community Health Clinic. And that location is open the second and fourth Monday from 1 to 4 p.m. At Coal Country Community Health Clinic, they also do have a MAT program that is open on the 1st and 3rd Mondays of every month, so we do collaborate quite a bit with them as well. Next slide.
Great. Both of those programs are just incredible for the support they've received and the number of people you've served. Your statistics are really impressive and also alarming at the same time. So I know that we have some questions. We have, Carrie, I'm just going to ask you, do you have some questions in the chat right now? We're going to open up the time. I want to remind you there is a questions chat box on the platform. And so we're going to encourage you to put your questions there, and then Carrie can bring them forward for either Dr. Tamang or Jennifer to answer. So Carrie, I'm going to just have you.
Yeah. Can you hear me okay?
Comments. Yes, can hear you.
All right. We do have a couple questions. The first is for Dr. Tamang. The question is, how does Project Recovery address the social determinants of health that patients are facing that may impact their addiction and recovery?
Dr. Tamang, you need to hit *6 on your phone to unmute. I think you're muted.
Yep, *6, please.
Okay. Thanks for the question. It's all about kind of triaging what resources are available. We try to do a very good job at the scope in which we practice. And so our primary focus is opioid use disorder, and we stay as tight in that lane as we can. However, there are occasions where patients need more, and we meet that need however we can. The majority of the ancillary services we perform involve peer support. We have 5 full-time peer support specialists on staff that work with patients quite a bit. And we also, of course, have a number of partners. Those relationships are great, but it's always tough when you're doing just a referral basis. There's a huge drop-off when you refer someone to a different entity. So we try to do warm handoffs whenever possible. I would say mental health is the other group. We had partnered with Cornerstone Rescue Mission and worked with them. And despite both groups putting in great effort, that relationship just became more or less untenable due to the patient situations. Transportation and management of the homeless was very difficult. So we try everything. We fail plenty of times, but we try to do our best to find innovative approaches to kind of take care of the whole patient. But I think it's important when you have a project like ours that when we do act, we try to stay within our lanes to provide an optimal service.
Mm-hmm. Excellent. Dr. Tamang, there is one more question for you, so I'll just relay that. And then, Jennifer, I have one that I'll send your way. What are some lessons learned or advice that you have for using telemedicine when treating opioid and alcohol addiction?
So the biggest thing when you're using telemed for MAT is that you understand the laws appropriately. Medication-assisted treatment for opioids typically is going to involve buprenorphine, which is a controlled substance. And so it's very important that you know both the federal laws as well as state laws and the local exemptions, and that you're up to date on how those change. I can tell you that traditionally before COVID, the primary law that dictated how to care for telemedicine patients was the Ryan-Hyatt Act. And basically that prohibited prescription of controlled substances without an in-person visit. So you could not initiate MAT services with a controlled substance without an in-person visit first. And then after that, you had a certain amount of leeway. Now that also has to run into state regulations, so you have to be mindful of that. COVID declared an emergency, and the DEA executed leniency on that. So there is a current exemption in place where you can initiate it. it's interesting, a number of organizations have emerged to prescribe controlled substances without ever seeing the patient in terms of medication-assisted treatment. And the jury's kind of out on that, how effective that's going to be. I can tell you that anecdotally, during our time taking care of MAT patients over telemedicine, I think the key piece that we learned was that the urine drug screen matters. And when you don't have that element, the histories really didn't necessarily match the facts as well. So while we're definitely a harm reduction orientated organization, a degree of accountability with the urine drug screen we found to be very important. That's not to say we don't do telemedicine. We do quite often if there's circumstances which necessitate it. Patients are traveling around the state. Patients have weather, car problems. Patients are sick. But as a routine basis, we try to keep the urine drug screen as a component because without it, we found anecdotally, again, that our results weren't as good.
Excellent. Thank you. All right, Jennifer, there's one question that came in for you. What advice would you give to another community or organization looking to implement a syringe exchange program like the Good Neighbor Project?
I guess one of the biggest things I would do is make sure that you get community buy-in. That was one of the requirements we had set forth from us by the State Health Department. And surprisingly, we didn't get a whole lot of pushbacks from local neighbors close to our office. But one of our biggest barriers still to today is law enforcement. We understand their fight against the drug opioid epidemic and everything like that. We were just wishing that they would be more on board with our program and how we could collaborate and work together better. That is one thing we still continue to work on, is improving that relationship, offering, when they do pull over people who have paraphernalia and sharps on them, rather than throwing them in the garbage or whatever they do with them, to call us and we go pick them up. So definitely community buy-in and a lot of collaboration with community stakeholders.
Excellent. And Stacey, that is the last question I have. So I'll turn it over to you.
Okay. Thank you. Well, again, if you have more questions, go ahead and put them in the question and chat and we'll address them. But as we wait for any others to submit their questions, I'm just going to share some details as we close out. Each attendee will receive a certificate of participation that you can submit for credit to any of your applicable accrediting or licensing bodies. Great Plains Quality Innovation Network is an approved provider of continuing education with the North Dakota Board of Examiners for nursing home administrators and the South Dakota Board of Nursing Facility Administrators. Also, you will be dropped off with an evaluation form at the end of the presentation. So we just ask that you take a minute to complete that, and we appreciate it. It helps us to plan and coordinate our future events. So I know this area, especially with the added stressors of the pandemic added on to normal life, substance abuse and recovery is challenging for the entire state. And you saw the numbers. I think it was over double your numbers from 2019 to 2020, Dr. Temeng, when you had your statistics up and projecting almost 10,000 for this year. So clearly this is something we want to continue to engage as a state and a healthcare community to make those referrals, make those recommendations, and just be aware of the resources that are available to us across the board. So I just want to thank each of you for the amazing work that you've been doing in your communities and in your respective expertise areas to continue to fight this battle. And so with that, was there any other questions that came through, Carrie?
None as of yet.
Okay. So we're going to go ahead and close out the session for today. If you have additional questions that come to mind, please feel free to contact us. And you'll also be able to access the recording and the additional presentation materials on the GreatPlainsClin.org website. So thank you all. Enjoy your day.
Thank you.